Hi, everyone. Thank you guys so much for having me here. It's so nice to see so many of my patients in the crowd. You guys are going to be bored because I've talked to you about this stuff so many times. So my name's Joe. I work at Memorial Sloan Kettering. I work in the mesothelioma program with Dr. Zouderer. So I just kind of want to acknowledge Dr. Zouderer and our meso team at MSK and all of our patients. Professionally, I am newer to the meso world, especially, in such an established community that I had no idea kind of what was going on up until this conference today. Dr. Zouderer has, transformed my professional career in introducing me to this world of meso and introducing me to you all. And I'm so grateful for being a part of this, and I can't wait to do future work with the organization. So just real quick, this presentation, we're going to talk about symptom management. I do want to let you guys know that the most important team to talk to about symptom management is your individual teams. These are my and Dr. Zouderer's and MSK's standard of care when it comes to dealing with symptoms. So just keep that in mind going forward. I'm always welcome. You guys are welcome to raise your hand and share things that you felt worked well with you or put input. So we're going to start off with defining palliative care. So according to the NIH, palliative care is specialized medical care for people living with a serious illness, such as cancer. Palliative care is meant to enhance a person's current care by focusing on quality of life for both patient and family. I think there's this misunderstanding of what palliative, or at MSK we call supportive care, is. There's a misunderstanding, and it often gets confused with hospice. So when you have a disease like mesothelioma that really encompasses every part of your health, we have to talk about symptom management and how to control the side effects of treatment and the disease. And what we do is we bring on supportive care and palliative care teams, which are teams that really specialize in how to troubleshoot those symptoms. So today we're going to focus on some of the most commonly reported side effects and symptoms of treatment of mesothelioma. We're going to talk about respiratory symptoms, gastrointestinal symptoms, pain management, psychosocial support, and cancer-related fatigue. So jumping right into cough. So up to 27% of patients with pleural mesothelioma report a cough. And it can be really difficult to kind of treat. So what we're first going to do is work with our providers. We want to rule out reversible causes like infection and treating the source of the cough. Non-pharmacological interventions can sometimes be somewhat limited. I don't know if any of you guys have ever had kids with whooping cough or anything like that, but you probably remember steaming up a bathroom to help them breathe at night, help them troubleshoot the cough. So one thing that's going to help is humidifying the air in your bedroom or you're in your home. For acute episodes, you can go into the bathroom or kind of breathe over a bowl of hot water to kind of moisten the airways. Lozenges and hard candy really help. And then something that's sometimes surprising is adding honey to your warm beverages like tea can really be soothing. We do want to make sure that the honey is pasteurized. One of the reasons for the pasteurized honey is because a lot of our patients are immunocompromised, so we have big concerns for botulism. Did you have a question? So honey is anti-inflammatory. It's natural anti-inflammatory. So it's just one of the things that we find really helps our patients. So moving on to pharmacological interventions, which I'm sure many of you guys are very well acquainted with. So we have kind of two types of medications: cough suppressants and expectorants. And it's kind of important to differentiate the two of them. Because cough suppressants are going to control your cough reflex. And we're talking about over-the-counter medications called Robitussin or Xylem. And these are best for dry coughs. And when we talk about cough suppression and dry coughs, we don't want to suppress a cough that is productive. Because if we're coughing up mucus, we want to cough up the mucus. We don't want that to sit in our airways and clog up our airways. Prescription medications that your doctor might prescribe are benzonatate, found in Tessalon. That's going to go ahead and numb the linings of your airways and your pleura. And then codeine, which is a narcotic medication that can suppress the cough reflex. And we typically like to use it in our practice with PM coughs because it can cause some drowsiness. Expectorants, these are going to help you expel mucus and respiratory secretions. Obviously, they're helpful in productive coughs. Over-the-counter medications, there's only one, and it's guaifenesin or Mucinex. It's the only FDA-approved cough expectorant. You used to see a lot of phenylephrine, and recent studies have shown that phenylephrine is no longer indicated. It did not show that it actually helps expectorate anything. So dyspnea, up to 60% of patients with pleural mesothelioma report shortness of breath. Obviously, the best way to treat dyspnea is to treat the underlying disease, but it's not always possible because disease progression is sometimes unavoidable. So we have a couple things that we can do for dyspnea. One of them is oxygen supplementation in the setting of hypoxia or low oxygen settings. You can test your oxygen settings with a pulse oximeter that will go on your finger at home. If you're calling your doctor's office, it's always useful to have your pulse ox readings for them when you call the office. This really gets a sense of where your oxygen levels are sitting, but we only use oxygen in settings, especially when we're not in a hospice setting, for patients with hypoxia. Oxygen itself does not make patients feel less short of breath unless they're hypoxic, unless their blood oxygen levels are below a certain level. It can also be a little bit of a barrier too, because sometimes patients really want to have oxygen, but there's specific criteria in which our insurance companies will pay for it. So you have to go to your doctor's office and actually have a test that shows that your oxygen levels are below a certain point, and you will qualify for home oxygen. And then we talk about narcotic and opiate medications. So we're talking about medications like morphine, Dilaudid, and fentanyl. They can be used to treat your shortness of breath. A lot of times in this instance, when it's not related to hypoxia, we talk about as air hunger or that need for air. And opiate medications work in two ways. They really suppress the central nervous system that has that respiratory drive and kind of decreases our feelings of air hunger. But they also allow for vasodilation of the blood vessels in our lungs, which allows more blood to reach our lungs, more blood to become oxygenated. So there is also a clinical benefit from using these medications in these instances when it's very difficult. The use of these medications will usually be directed by a supportive care or a palliative care team. Our team doesn't typically prescribe opiate medications just for air hunger and stuff like that. Your team may also use steroids to reduce the inflammation in your lungs. If it's clinically indicated, that's going to be a case-by-case basis. Moving on to gastrointestinal symptoms. So I think one of the big ones that we talk about is weight loss, particularly with peritoneal and sometimes pleural mesothelioma. So 44% of patients with peritoneal mesothelioma and 29% with pleural mesothelioma report weight loss. Nutrition in patients with cancer can be challenging because the systemic treatment can cause a decreased desire to eat, and it can cause changes in our taste buds. Our taste buds, the lining of our tongue and our mouth, are very rapidly dividing cells, so sometimes chemotherapy can catch those cells in the crosshairs and kind of change how we taste. So we're talking about nutritional supplementation in this case. So especially in patients that have early satiety, our peritoneal mesothelioma patients, when you're feeling full very quickly in a meal, we counsel our patients to eat small meals 8 to 6 times a day, as opposed to 2 to 3 times. That lets us get more food in more frequent intervals. And then indulge in high-calorie beverages, drink your milkshakes, your hot chocolates, your fruit juices. If you're in a calorie deficit, we want you to get those calories so that we can maintain our weight during treatment. Make foods that smell good, like bacon, bread, or baked goods. We have to also keep in mind, if you are someone that's nauseous, we'll want to avoid the high-smelling foods, because sometimes that can aggravate it. But if you're not nauseous, then consider those. keep high-calorie snacks available when you go on the ready. Increase your protein intake, so thinking lean proteins like chicken, fish, pork, beef, lamb, eggs. You can add unflavored protein to your soups if you're eating soups, if you're drinking broths, stuff like that just increase your intake. And then talk to your care team. We have a couple dietitians and nutritionists in the crowd today. They are our best resources for helping with nutritional needs. We can talk to them about whether things like Ensure will be appropriate for you. However, when we talk about Ensure and nutritional supplements like that, we have to keep in mind that they are specialized for your clinical situation. So there are specialized formulas for patients that have kidney disease, liver disease, stuff like that. So pharmacological interventions. So there are some medications that can help when dietary changes aren't enough. So we're talking about Marinol or Droabenol and Magistrate or Magase. So Marinol is a synthetic cannabinoid. It was developed to bind with the same receptors that marijuana bind with that give you that munchy feeling. And then it's originally approved for patients with HIV and AIDS in their nutritional lack, and it has since then bridged the gap to our patients with cancer. It can also help with nausea and vomiting after chemotherapy. It can be challenging to get insurance verification for this because it is considered an off-label use of the medication. And then Magase, which is a medication that we think stimulates the hormones and improves your appetite, but it can take up to 12 weeks to work. So this one is a little bit more of a longer-acting one. Steroids can be considered by your treatment team to increase weight, but sometimes it's unclear if the weight gain from steroids can just be from water retention or from true nutritional increase in your lean muscles and fat. Oh yeah.
Just on the nutrition idea, should I be worried about what I'm eating, or should I just be eating? Because sometimes I just really don't feel like eating kale. I just need a piece of toast, so
Can you repeat her question in the mic?
toast?
Yeah.
Or should I force myself to eat some kale?
So her question is, in times when she's not feeling particularly hungry, whether she should be forcing herself to eat things that we would traditionally be labeling as healthy, like kale, if she just really wants toast. And I would say that there's no reason that toast isn't healthy. Toast, multigrains are these things, these Pop-Tarts, anything that's helping us get to our caloric intake. And of course, we want to be conscious of protein intake and stuff like that. But don't force yourself to eat kale if you don't want to eat kale. You can eat the toast, peanut butter and jelly sandwiches, things that are making you feel good and full, okay? So, a quick sidebar on medical marijuana. For this very ambiguously worded slide, we're not sure the true benefit of medical marijuana. It's still being researched, and I think that a reason for that is because in the United States we have a severe lack of regulatory oversight in the production of marijuana. So it's hard to really study it based on doses because we don't know where it comes from and stuff like that. So we never encourage our patients to smoke marijuana, especially our pleural mesothelioma patients, because it can aggravate the lining of your lungs and increase your coughing. There might be a use of cannabis in other forms like topical, oral, transdermal, but you can explore this with a licensed medical provider. Some supportive care teams can prescribe medical marijuana to you. I know in New York, there's an online registry of people that are specialized in this and can help. So I do encourage my patients to look into this if they're interested. So moving on to nausea, and, yeah.
I'll say my mother was using it.
Yeah.
She found it very helpful. She was a peritoneal patient as opposed to lung patient, so from that perspective, I think a different view of it, and she preferred the gummies to smoking.
Yes.
Also just because of the issue, so it did help her.
Yeah, it can help. A lot of our patients find it helps not only with hunger and eating, but also anxiety and sleep. So it is a medication that can have multiple uses, and I do think that there's a role for it in the treatment of this disease. We just have to study it more. Just to reiterate what she had said for the people online, she just said that her mom had a peritoneal mesothelioma, and she found ingesting marijuana through edibles to be very helpful. So nausea and vomiting. Chemotherapy medications are typically what we're talking about when we're talking about nausea and vomiting. They can affect the areas of your brain that trigger nausea and vomiting. So non-pharmacological interventions. So the moms in the room probably remember morning sickness. When you wake up in the morning, if you're someone that is instantly nauseous, one thing that I tell my patients is to go ahead and eat some toast or dry crackers before you rise from bed. It can bind with some of the stomach acids and help you from that instant nausea when you stand up. Always sit in an upright position and try to remain upright for 2 hours after eating. Avoid those fatty, greasy, creamy, spicy foods that can sometimes trigger our stomachs to revolt against us. And hard candy can also help with this. So especially ginger. Ginger candies can really soothe the stomach. Peppermint candies can really soothe the stomach. Pharmacological methods of management, your team will have their own kind of regimen to help you with this. We typically use ondansetron or Zofran, but we can also use olanzapine, Reglan, Phenergan, Compazine, and sometimes Ativan, which is an anxiety medication. So, diarrhea. Up to 33% of patients with peritoneal mesothelioma experience issues with digestion. So there's a wide range of reasons why diarrhea can occur, and they're not limited to tumor burden, systemic treatment, localized treatment, and narcotic use. Diarrhea, we first need to establish the etiology of why it's going on before we can treat it. So the first thing that we typically do is we're going to have you send a stool sample in to make sure that we can rule out infectious symptoms. Because we can't use antidiarrheals in patients with infections, particularly C. difficile, because what we do then is we bind up the disease in our colon and it kind of releases toxins that can cause us to become more and more sick. So before you take an antidiarrheal, make sure you talk with your care team so that you can rule out infectious symptoms. And then we can move into treatment of it. So non-pharmacological interventions, starting off, I'm sure you've heard this before, the BRAT diet with an extra T. So BRATT stands for bread, rice, applesauce, toast, and tea. Tea can help soothe patients' stomachs. We're talking, in general, though, this is a bland foods diet. So we consider this for acute, not chronic diarrhea. Of course, you can't live your rest of your life just eating those 5 things. But this can sometimes help in the acute setting. Avoiding high fiber foods, especially in the acute setting, fiber can exacerbate diarrhea. Sometimes it seems a little counterintuitive, but at the beginning, when we're talking about this, we try to avoid the high fiber foods. Avoid fat foods. Again, this is a recurring theme. Things with heavy cream, fried food. Prevent dehydration. This is huge. You lose a lot of electrolytes when you have diarrhea. So we like our patients to drink as long as your team can tell you can tolerate up to 2 liters of fluid a day. Make sure you're supplementing in some electrolyte replacement, especially if you're having frequent diarrhea. And then the last one is taking care of that booty. So I'm sure we've all been there where we've been having frequent diarrhea. You really have to care for your skin because this can cause breakdown, a lot of issues. So we're talking about sitz baths. We're talking about warm showers after episodes, using A&D ointment on our skin, just taking care of it. And this is a little bit of a weird topic to be talking about, but as your guys' nurse, you can come talk to me about it anytime. That's what we're here for. And then pharmacological interventions. So after infections and inflammatory systems have been ruled out, colitis, C. diff, stuff like that, we're going to move on to things like loperamide, which is Imodium. You can buy that over the counter. We typically use an episode-based dosing for that. Bentol, which is an antispasmodic, which slows down your gut motility. And then Verbinzi, which is also an antispasmodic that decreases diarrhea. It is a newer medication. I have not used that yet. And then the opposite side of this coin, constipation. So up to 33% of peritoneal mesothelioma patients experience issues with digestion. I know I said that in the past. So constipation can be due to tumor burden, polypharmacy. It can slow gut and cause obstructions. So maintaining an adequate bowel regimen is absolutely imperative. So non-pharmacological interventions, we're talking about bowel training. I think going to the bathroom at the same day every time seems like simple, but it actually does really help our patients if it's possible. Kind of training your body to go 10 to 15 times after meals. Exercise is imperative in getting your gut to move, getting up and walking. If you're feeling constipated, going out, walking around your block. Making sure you're drinking lots of fluid, 2 to 2.5 liters of liquid a day. Remember, our bowels move through the use of water to kind of loosen stool. And then prune juice. This is kind of the first thing I tell my patients with constipation to go to, prune juice, especially if you microwave it for 15 to 30 seconds. Sounds kind of gross, but the warmth can really help move things along, and prune juice is a natural kind of issue solver here. So pharmacological interventions, we have 4 types of laxatives or stool softeners that we use. Stool softeners, think Colace. So it's going to increase the water in your stool. You can take it typically up to 3 times a day. Docusate sodiums, the over-the-counter medication you can get at CVS or Walgreens. Osmotic laxatives, so Miralax, pull water into your stool and help things move along. Stimulant laxatives like Senecot speed up the muscle movement of your colon, so it's kind of didn't do the opposite of what that Bentyl does. But it can cause some cramping, so I usually tell my patients to take this at night. And then bulk-forming laxatives like Metamucil, Fiberol, all those types of things. So when we move into constipation, it's kind of weird that we would say for diarrhea, don't use fiber, but for constipation, use fiber. These things can really help your body become regular and increase the bulk of your stools. So make sure you're drinking it with plenty of water, because that's how it works. And talk to your physician before using this, because it can sometimes bloat. Okay, pain. This is a big one. 71% of patients with pleural mesothelioma and 63% of patients with peritoneal mesothelioma report pain. Non-pharmacological, we're talking about these integrative medicine things that really do help. I know sometimes we don't think that they do, but talking about physical therapy and occupational therapy to kind of establish where the pain's coming from and work. Neurostimulation, acupuncture, acupressure, transcutaneous electrical stimulation, it's called TENS. Counseling and hypnosis, these types of things. A lot of my patients will go to our integrative care teams and really find a lot of help, particularly in acupuncture. Treatment of mild pain in pharmaceutical is when we're talking about NSAIDs. So we really need to talk to our doctors about what NSAIDs are best for you, because they can affect your body in different ways. Sometimes Tylenol is what we would suggest, or acetaminophen. Sometimes it's ibuprofen or NSAIDs. So because of the treatment implications, you always want to talk to your doctor about the best agent to use for you. And then moderate to severe pain. So we're talking about narcotic and opiate pain medications in this instance. They can be ingested, inhaled, they can be patches, they can be shots, they can be pills. Opiates are used to control moderate to severe pain in cancer patients specifically. They can be administered at home. We're talking about codeine, fentanyl, hydrocodone, morphine, the list goes on and on. Many of our cancer patients rely on a regular schedule of opiate medications for pain management. Over time, your pain may require increased levels of narcotics to manage your symptoms. And I really want to be specific here when we're talking about tolerance and dependence. So when your body needs more pain medicine, this is called tolerance. It is not dependence. or it is called tolerance and dependence. It's not addiction. So your body can develop a physical dependence on these medications, but it's important to remember that a physical dependence is different than addiction, which is a psychological dependence. A lot of our patients get hung up on the rational fear of becoming addicted to opiate medications, and that is something that we really want to take seriously and identify with you, while also being sure that we're treating your pain in a way that is appropriate for your cancer-related pain. So I think this is an open and honest conversation you need to have with your oncologic team about what's best for you. And I do think a lot of times when patients present with cancer, their pain's very acute. And as we treat you and your disease gets better, we can wean those down. So that's something that you can do with your team. But in the acute phases of pain management, please don't be afraid to take the medications as prescribed. Narcotics can cause sedation, constipation, dry mouth, drowsiness, and respiratory suppression. And then it's always important to make sure you're on a good bowel regimen when you take narcotics because they do slow down your gut. And then we're going to get into that constipation issue, which we were talking about earlier. Narcotic safety. So I think not only with cancer patients, but in today's day and age, it's important to talk about narcotic safety. So talk with your provider about your concerns about addiction, and be safe with them. When you regularly take narcotic medications, keep the emergency medication called Narcan or naloxone in your house. Your provider can prescribe it for you with your narcotic medications, and some pharmacies across the US will give it to you for free now. Do not drive or operate machinery when taking narcotic medications. If you're my patient, I send this in every portal related to narcotics. Please don't. Keep your medication in a cool, dry place far away from children and pets, and then keep naloxone around. We're going to talk about how to give naloxone real quick because this is an important plug for meso patients, all patients, and basically everyone right now. So if you can carry Narcan with you, it's always important to have it in your bag when you're traveling on the subway, at the mall, stuff like that. So there are no negative side effects of Narcan. So you can give it to someone in cardiac arrest. If they haven't overdosed, it's not going to harm them. So the first thing you do is you check the scene is safe, make sure that it's safe for you to approach the person. You're going to call out their name, shake them, rub them, check for signs of opiate overdose. It would be slow respiratory rate or not breathing at all. Pinpoint pupils if you open up their eye and look at them. When you make the decision to administer Narcan, you're going to roll them onto their back, and you're going to hold the Narcan nasal spray with your thumb. You can see up there, it's a little cartridge. You gently insert the Narcan into their nose. You're going to put your hand behind their neck and tilt their head backwards and administer the dose. So press the plunger firmly to give the Narcan spray, remove the Narcan spray from the nostril after giving the shots, and then you're going to call 911 and you're going to place the patient into what we call a recovery position, which is a side-lying position with one arm down, just in case they vomit when they wake up. Watch the person closely. If they don't respond, you could administer subsequent doses of Narcan until emergency medical providers arrive. So you just revert back to step one or step two every 2 to 3 minutes with the Narcan. Procedural pain interventions. So real quick, I want to jump back to the Narcan. I think this is also nuanced in patients with cancer too, with your patients. So really consider, when we're in the acute phase of treatment, I'm asking you to use Narcan in these instances. But if you have a patient or family member that's home on hospice and stuff like that, that's when Narcan use becomes more nuanced. So go ahead and talk to your providers about that. Okay, anyway, jumping forward, procedural pain interventions. So we're talking about nerve blocks, cordotomies, and radiation therapies. So a lot of institutions have great procedural pain, anesthesia pain teams. They're going to go in and they're going to find where that pain's occurring, and they will do a nerve block, which is where they'll inject numbing medication around the nerve, and that can really numb a particular part of your body. Cordotomy is kind of used in the end-of-life treatment of cancer pain. It also inhibits cold and hot sensation. So this is where they go in and they actually just sever the nerve. So you're not going to feel anything to that part of your body, and it can work very well. Radiation therapy is also something that can really help with pain. If we have a nodule or a node that's really pressing on a nerve, causing patients to feel pain, we will frequently refer them to rad-onc, and they do experience benefit from that, and it works for a long time after you get the radiation as well. And then depending on the site of your cancer, we can sometimes give radiotherapy or cryoablation. We've heard that word today or this weekend a couple times. And then the big one that is really hard to treat is cancer-related fatigue. So I think it's important to note that cancer-related fatigue is different from the fatigue of people without cancer. I think in today's day and age, all adults are tired, but cancer patients have more fatigue than everyone else. And it's well documented, and you need to be validated in the experience of this fatigue. And it's because of the buildup of toxic substances in the cells that are killed by cancer and by treatment. So I think it's kind of hard to treat again, but we're talking about staying physical, using an activity log. So logging your activities, and then this can help you kind of talk to your team about what times of day you've noticed that you become tired. If you're able to walk in the morning, but you're tired in the evening, we can try different types of things. So note how you're feeling after activities and level of fatigue throughout the day. Physical activity, we're talking about 2 to 3 hours of exercise per week. So walking daily, getting in those steps, getting enough sleep. So if you can avoid napping for too long in the afternoons, cat naps are okay, 10 to 20 minutes, but we really want to save the bulk of your sleeping for the night. So keep lap naps to late morning and early afternoon, maintain a sleep routine with consistent bedtimes and wake-up times, and avoid caffeine, alcohol, and tobacco at all times, but especially after 6 p.m. Plan your activities. Prioritize what you need to accomplish every day so you can make sure that you get things done. Utilize your activity log to plan what time of day you'll schedule activities so that you can complete them at your highest levels of energy. Utilize your emotional support. Do not isolate yourself from your social circle. Spending time with your loved ones is super important and can alleviate sadness, depression, and that may be contributing to your fatigue. Get help with your anxiety and depression. Ask for help. Consider joining a support group like the ones that we had today with your family and friends who can help you manage. And then again, physical therapy and occupational therapy. It is fabulous for working on things like this at home. So bringing those people into your home, going to the PT/OT centers and working on that, they can really help you. Psychosocial support. So we spend a lot of time talking about physical health, but the mental, emotional well-being of our patients and their caregivers are just as important. So we need to utilize our multidisciplinary care teams, social workers, case managers, support groups, therapy, psychiatric health teams. I think one of the struggles of this disease, and I'll be somewhat frank, it affects our older generation a lot more than our younger generation. And our boomer generation is sometimes reluctant to accept psychiatric help and therapy, and this can be a really difficult thing for our population. So I think understanding that this disease really takes some of our psychiatric issues right out of our hands, it needs to be handled by a professional person that can help us process these emotions. Our social workers can help us get community resources, transportation to and from the hospital. A lot of times that's paid for by your insurance company, so talk to your social worker about that. Case managers can help you with your visiting nurse services, and our support groups, of course. And then that's why we're here today. So I don't know if you guys have ever heard of this great organization. It's called the Mesothelioma Applied Research Foundation. It's really fabulous. On the MESO website, you can find the travel grants, support grants, and valuable information on current treatments and care. There's also resources available through the American Cancer Society, cancer.org, and together we can find a cure. And then because this is a palliative care talk and sometimes disease is unavoidable, one thing that's very important to talk about is that despite our many advances in treatment of mesothelioma, it remains an illness with a high mortality rate. So it's never too soon to establish a healthcare proxy and talk with your loved ones about your healthcare wishes. There is a fabulous website that can help you have this conversation with your families, and it's called the Conversation Project. So go to the Conversation Project's website with resources how to have this conversation. They have the healthcare proxy forms, information on living wills, and power of attorneys, and you can find them at the conversationproject.org. these are my references, and this is Sloan's legal thing, and thank you guys so much.